Now, as I mentioned in class, this obviously is a sensitive area, so you want to be explain what you're going to do. This isn't something that typically I would do right off the bat unless somebody was referred to me kind of for this procedure. As you can understand, in the pelvis, all the joints are connected, particularly the SI and the pubic symphysis. Not that the acetabular femoral joint isn't. It is in there, but it's not necessarily on one end or the other of the ilium and the iliac, I guess, that makes up that pubic symphysis. So one of the ways that you can assess issues with the pubic symphysis is what's happening with either the ASIS or the PSIS, right? So you can check leg length as a way to see if there's any kind of an imbalance. Marie has a right leg. Yeah. A short right leg. So I could potentially expect that her ASIS would be, superior. Although when I'm checking, it doesn't really look that way, so I don't know. But sometimes when you check things out, it doesn't ever sometimes follow that. Or if a person was prone and you checked out their PSIS, because you would expect either it could be a shear, that's one way to look at it. But if there's a posterior rotation by a pelvic imbalance, it's going to affect the pubic symphysis. So when you look at the pubic symphysis over here, I recommend starting at the ASIS and then kind of palpating down with your palm, so you're going down the ala, and you end up here at the ramus. And then you're going to palpate and do joint play. So what I usually suggest doing is starting so that my hands are on the ASIS as my the thenar and hypothenar eminence, and then I just kind of come down the rami until I'm on that rami. I can do joint play like this, seeing if there's any resistance. I can translate it to my thumbs and palpate to see if one is superior or inferior. Usually if there is a rotation this way, this rami is going to go superior, right? Or if it's gone in an AS direction, and that rami would be inferior. So again, sometimes understanding your anatomy gives you that sense of what to expect. Now in the recommendation for correction, this is primarily using kind of muscle energy type technique as opposed to a frank thrust. Although you could potentially do that by using kind of a covered thumb or unilateral pisiform, or you could use a activator, which is an instrument manipulation device, to do that correction as well. As I mentioned in class, male and female have different anatomy, and in female it's easier to do the procedure in some respects because in males sometimes their penis, when they lay down, could be laying up on the pubic symphysis. So a couple of ways, as I mentioned in class, gravity kind of helps. So the penis will just go dependent or go inferior, or if it happens to laying there, usually if you're anticipating doing this procedure, you would anticipate getting them kind of properly set up. Or you could just ask the patient to reposition themselves, or you can just tell them that you're going to reposition them and just kind of move their penis out of the way and like that. So in relationship to the evaluation, if you get the information that yes, there is a superior rami or inferior rami, or there's restriction in the joint play, or sensitivity. Again, these are all different things that you would expect to be a sign of misalignment. So the procedure, the choreography, is that you want to start with the superior rami. And so if the rami has gone superior, you want to make it go that direction, right? You're going to want to extend the pelvis. And so the way that you're going to do that, scoot a little bit closer to the edge of the table. Okay. So this one leg comes off, and I'm using this one leg here to kind of support it. The reason is, if this person brings their leg out and puts their leg like that on the table, on the floor, if I try to push this down to extend the ilium, it's not going to happen, right? Mm-hmm. So the leg needs to be straight out. So sometimes people are pretty good about holding it that way, but if not, you can just use your leg to kind of hold it that way. And then what I'm going to do is use my hand kind of here on the femur and on the ilium and push down. So you see how that's making this go into extension? And so that's going to rearrange that rami. And so this is where kind of muscle energy or muscle resistance comes into play. So I'm going to stretch it into that position. Then I'm going to ask the patient, push your thigh up to the table, or up. Okay, let yourself relax. And then I can get another little push. Push up again. Let yourself relax. Kind of stretch it out. Push up. Let yourself relax, and then kind of push back down this way. So this is encouraging muscle dynamics, as well as that aspect of just pushing in the right direction. Now, come on, just lay straight up. Now, how this procedure actually starts, and I forgot to show you, but the legs start out up and knees like this. And then what I'm going to do is I'm going to separate them, but the patient's going to resist. So this is kind of the resistive component. So I'm going to pull out. Don't let me. Resist. Okay. Relax. Now I'm going to push in. Don't let me. Relax. So I'm getting the abductors and the adductors, which have that, particularly the adductors, is they insert around the pubic rami. So I do this 3 times. Okay, I'm going to push out, hold. Good. Relax. I'm going to push in, hold. Good. Relax. I'm going to pull out, hold. Okay, relax. I'm going to push in, hold. Relax. And so your patient starts to get the idea of what to do when you do that. I might do it a little bit slower, but I'm just kind of trying to get through it. And then I would lift their leg off the table and do that, okay? And then I would bring them back up to do this, which I just did. And then the other component is to take this side, would have been the inferior rami, correct? So when I'm going to push her into flexion. So that's going to make that rami go like that. So that's going to bring it from inferior to superior. And if I needed to, I can kind of grab the ischial tuberosity and kind of help with that rotation. So once I've made that stretch, then what I'm going to have the patient do is push against my chest with their leg about half their force. Push up. Okay, relax. So this is kind of that muscle energy component of it. And then I can kind of re-stretch. If I need to do it this way, I get a little bit extra. Okay, push up against. Okay, relax. That 3 to 5 on, 5 to 7 off. Stretch again. And then one more time, push up. Okay, good. Let yourself relax. And then I'm going to bring your legs together, bring your knee up. So then I'm going to go through the in, out thing again. So I'm going to pull out, relax. I'm going to push out, hold. Now relax. I'm going to push in, hold. Good. Okay. Now I'm going to pull out, hold. Okay, good. Now I'm going to push in, hold. Okay, good. Now I'm going to pull out, hold. Okay. And then to finish up the procedure, I'm going to bend my wrist like this. Put it between the medial knees and ask the patient to squeeze kind of hard as they can. Just a nice, good squeeze. Okay, good. Sometimes when you do that quick squeeze, you'll sometimes hear a little pop, which is where, after doing all that work, the pubic symphysis will reposition. And this would be the point in time after I've done all of this that I would potentially consider using a direct kind of contact, either, again, covered thumb, unilateral pisiform, or using like an activator. And then as I described earlier in class as well, when I'm palpating it, I always start this way, end up this way. I never start this way and go down that way. So I don't do this very often. And sometimes when I do it, I pull out my sheet in my office just so I don't forget the sequencing. But, again, if a person has had chronic genitourinary issues, that does not respond to other mechanisms that you've done, you would imagine that working with the SI joint would also affect the pubic symphysis in terms of manipulation, even potentially doing what we're going to do next in terms of pelvic shear correction or hip issue. That might also have an effect on this as well. But if it has not responded to your satisfaction, or it could be, frankly, that the person just has pain right there. I had a patient who was kickboxing, and somebody just, it was a female, they just, when they kickboxed, just knocked her right there on the pubic symphysis. And so, that was like a direct kind of impact. And so this procedure kind of helped, reorient the structure and the alignment. And then, she felt much better after that. So there's like, in anything, there's the right time to use the particular, manipulation. So again, this wouldn't be the first thing that I would do typically, but in the context of the whole picture, I would correlate their symptoms with, less time. Now we've tried other things that hasn't involved that, genitourinary or, anterior pelvic, pubic symphysis, pain is still present, so then I would, opt to do this particular procedure. All right? Everybody's got that? So I'm going to let you practice that up. Yeah, Ben.
So